So, we're still thinking about heart failure and the causes of heart failure. And in this video, we're thinking about the causes of right ventricular failure. So this is the right side of the heart here. Here we have the right atrial myocardium. And here we have the right ventricular myocardium. And of course, the right side of the heart is the lung pump. It's pumping blood to the lungs via the pulmonary artery. Once the blood's been through the lungs, it's draining back in the pulmonary veins, represented here, to the left atrium. So we're thinking about right heart failure. And particularly we're thinking about right ventricular failure. Failure of the right ventricular myocardium. And as we've done before in these diagrams, we've just coloured the myocardium in red to sort of accentuate its importance. Now, the main cause of, the most common cause of right ventricular failure is actually left ventricular failure. So left ventricular failure, and we've seen the causes of this in the previous video, left ventricular failure will cause right ventricular failure. Now, we've actually alluded to this before, but let's just run through it briefly here. So if the left ventricle is failing and not pumping properly, there's going to be a residual volume of blood left in the left atrium. That means the blood's not going to go for, sorry, left in the left ventricle there. So residual volume of blood in the left ventricle there. Now that means blood from the left atrium is not going to get through normally. That means the blood's going to dam back in the pulmonary veins all the way to the lungs, and we're going to get damming back of blood in the lungs. So the lungs are going to become congested with blood as a result of left ventricular failure. Now we've noticed that this can happen acutely, but often this develops over many years. So we get pulmonary congestion. Now if the lungs are congested with blood, that's going to make it harder for the blood to go against the increased pressure of blood in the lungs from the pulmonary artery. So what that means is that the right ventricle has to work harder to pump the blood out. We increase right ventricular workload. And as we noticed before, we'll get right ventricular hypertrophy. It'll initially get bigger. Hypertrophy. Now, hypertrophy means an increase in the size of the cells that are already there. It's not a hyperplasia. A hyperplasia we get in tumours, for example, where there's an increase in the number of cells. This is a hypertrophy. The cells get bigger. So if you go down to the gym and start working out, your biceps are going to get bigger. And the reason they get bigger is because the individual cells get bigger. That's hypertrophy. So the same thing happens in the right ventricle in response to the increased workload. And for a while that will compensate and the circulation can maintain. But over time, the right ventricular hypertrophy will lead to failure. The heart will get bigger initially and compensate. But what actually happens is the high workload causes damage to the individual myocytes, the heart cells. The cells that make up the myocardium, and they accumulate fibrous tissue which is non-contractile. So over time the contractility of the right atrium will be reduced and it won't be working properly. Now if the contractility of the right atrium is reduced and it's not contracting properly, that means there's going to be a residual volume of blood at the end of systole in the right atrium. That's going to make it harder for the blood from, in the right ventricle. There's going to be residual blood left in the right ventricle. That's going to make it harder for blood from the right atrium to get through to the right ventricle. So it's going to be harder for blood to go from the right atrium there through to the right ventricle there. And that means the blood's going to dam back in the systemic veins, which are here. This is the inferior and superior vena cava represented here. and that's going to dam back, and it's going to dam back into the tissues of the body. And that's going to lead to systemic edema. So the right ventricular failure is going to cause systemic edema. In the UK, we put an O on the front. So that's the mechanism there. Now, again, just what actually happens is if we consider a capillary, systemic capillary. So there's the systemic capillary with its thin endothelial cells. Capillary is just a tube, of course. Now, normally, when the blood comes in at the arterial end of the systemic capillary, the pressure is going to be about 35 millimeters of mercury. And by the time it leaves into the venous end, because of course the venous system is a lower pressure, that's going to have dropped down to about 16 millimeters of mercury. But the large plasma proteins generate an osmotic pull of about 26 millimeters of mercury. So here we see that the hydrostatic pressure is greater than the osmotic pressure, so the tissue fluid is going to be formed. Formation of tissue fluid, which is good, of course, we need the tissue fluid. And normally the 26 is greater than the 16, so it's reabsorbed. But if there's congestion, if the blood is not getting from the body into the systemic veins, there's going to be an increased pressure in the systemic veins. And we know that because if you look at the jugular veins, you can see that these patients have increased jugular venous pressure. The jugular veins become congested with blood. So if there's an increased pressure in the systemic veins, that's going to dam back to the systemic capillaries. And that means instead of being 16 millimeters of mercury, that pressure is going to be raised, and that's going to lower the difference between the 26 and the 16. So less tissue fluid is going to be reabsorbed. And when less tissue fluid is absorbed, it accumulates in the tissues as edema. So these patients become edematous. So right ventricular failure, most commonly caused by left ventricular failure. But there's a list of other causes here to think about, and we notice that pulmonary heart disease is another cause of right ventricular failure. Now, what's happening here? Well, the blood from the pulmonary arteries, of course, is going to the lungs. And this, of course, breaks up into a whole host of smaller blood vessels, taking the blood to all parts of the lungs. It's very complicated, actually. It's quite amazing that the pulmonary artery actually forms a fractile tree, taking blood to all parts of the lungs. And this gets through the this all goes through the pulmonary capillaries and eventually draining out So what we're imagining is here is that these are pulmonary capillaries and these are pulmonary capillaries, and they all collect and drain out like this, taking the blood back into the pulmonary vein. Now, there's a bit of physiology here that we need to kind of understand to see what's going on. Now, if we imagine, let's imagine an ordinary, let's suppose this is the arterial branch is going to some tissue, some body tissue. So here's a body tissue. This is a tissue in the body over this side. It's a body tissue. Now, if there's a lack of oxygen in the tissue that's normally supplied by a branch of an arterial, say, if there's a lack of oxygen in an area of tissue, we call that hypoxia. So there's a lack of oxygen in an area of tissue. Now, if there's a lack of oxygen in an area of tissue, do we need more or less oxygen to get to that area of tissue? Well, obviously we need more oxygen to get to it. And the only way the oxygen gets there is in the red blood cells, in the erythrocytes. So we need more red cells carrying their oxygen to get to the tissue. How do we get more red blood cells to the hypoxic area? Well, we need to get more blood to the hypoxic area. So what happens is this vessel needs to dilate to get wider. So we've got more blood. So when there's hypoxia in a tissue in the body, that leads to vasodilation. To get more blood and therefore more oxygen to that area, thereby relieving the hypoxia, which is what we want. Now, in the lungs, because what's happening in the lungs is the lungs are adding oxygen to the blood. They're adding oxygen to the blood. So let's suppose there was an area of lung here, and this area of lung was diseased for whatever, lung disease. And that area of lung is not functioning properly. Suppose no air was getting to that area of lung because the bronchial passages were blocked off. Now, if there's no oxygen in that, or there's little oxygen in that area of lung, let me ask you: is there any point sending large amounts of blood to that area of the lung to pick up oxygen that's not there? Well, obviously not. So if you want to buy a loaf of bread, there's not a lot of point going to the butcher's shop because that won't have bread. You need to go where the bread is to pick up the bread. So what happens in the lungs is if there's an area of the lung where there's a reduced amount of oxygen. So there's a reduced amount of oxygen now in an area of the lung, in the alveoli, then there's no point sending a whole load of blood to that area to pick up oxygen that is not there. It would then drain out in the into the pulmonary veins because the oxygen's not there. So there's no point sending a lot of blood to pick up the oxygen. So what happens is the opposite reflex takes place. So in the body, in the somatic tissues, when there's a deficiency of oxygen, there's a vasodilation. In the lungs, when there's a deficiency of oxygen, there's a vasoconstriction. The vessel gets smaller because there's no point sending it to pick up oxygen that's not there. So lack of oxygen in the lung causes vasoconstriction. Vasoconstriction. And can you see if this happens in a lot of the lungs, if there's vasoconstriction in a lot of the lungs, that means the total lumen of the pulmonary vasculature is reduced. So now, because there's not much oxygen in this part of the lung, but let's suppose there is plenty of oxygen in this part here is okay. So that part of the lung's fine. So now we're going to get constriction of the pulmonary vessels to the area of lung where there's not much oxygen. Those vessels are going to get smaller. No point sending blood there. Nothing to pick up. So that means that we've got a reduced overall lumen. So instead of having that lumen and that lumen plus that lumen and that lumen, now we've only got that one. So what we've actually done is we've reduced the cross-sectional total area of the lung vasculature. And when we reduce the lumen, what do we do to the pressure? Well, when we reduce the lumen, that's going to increase the pressure. So we're going to increase the pressure as blood is shunted away from areas of the lung which are not well oxygenated, because vasoconstriction will increase the pressure. Blood pressure is cardiac output multiplied by peripheral constriction. So if there's more, but by peripheral tone. So if there's more peripheral vasoconstriction, the pressure is going to go up. So that means that the pressure here is going to be higher. There's going to be a higher pressure of the blood in the pulmonary artery. It's going to increase the pressure. So lung disease will lead to pulmonary artery hypertension. And the normal blood pressure in the pulmonary artery here, the mean blood pressure is about 11 to 17 millimeters of mercury. That's the mean blood pressure in the pulmonary artery. Of course, in here, in the systemic artery, it'll be about 100 or 95 or something, much higher. And we don't want it to be higher than 20. 20 would be considered the max for the normal. In fact, if it's 21 to 24, that's abnormally high. And we normally diagnose pulmonary arterial hypertension at greater than 25 millimeters of mercury at rest. Anyway, the point is that the pressure in the pulmonary artery is increased. If the pressure in the pulmonary artery is increased because of the vasoconstriction in aspects of the lung vasculature, so we've got more back pressure here in the lungs from the vasoconstriction, that's going to increase the pressure in the pulmonary artery. What's that going to do to right ventricular workload? Well, if there's an increased pressure here, obviously that's going to increase right ventricular workload. And if we increase right ventricular workload, remember this story, we get the right ventricular, initially we get the hypertrophy, we get the compensation, but that will lead to failure. The myocytes become fibrosed, and there will be reduced contractility of the right ventricle, which is right ventricular failure. And if there's right ventricular failure, the blood in the ventricle is going to be a residual volume because the blood in the right atrium can't get through. That's going to dam back into the systemic veins, and the patient's going to get systemic edema. So that's why chronic lung disease, or indeed any lung disease, deficiency of the lungs, when the lungs aren't oxygenating properly, that can lead to edema. So very often we see this in chronic obstructive pulmonary disease patients. They become edematous, and if they're hypoxemic, they can also be somewhat cyanosed. That's why we can sometimes say these patients become blue and bloated. So the key thing to grasp here is lung disease causes heart disease. Lung disease causes heart disease. And of course, if there's as we've seen before, if there's a right ventricular failure, that will also lead to a left ventricular failure. Because if there's a right ventricular failure, the blood's going to dam back and it's going to increase the pressure and increase the left ventricular workload, as we've noted. And that's called pulmonary heart disease. So pulmonary heart disease is heart disease caused by pulmonary disease, caused by lung disease. And initially it's a right ventricular failure. Sometimes that's called cor pulmonale. It's probably a bit of an old-fashioned term now. We normally say pulmonary heart disease. But if you see cor pulmonale, that's what it means. It means heart disease caused by lung disease. Right ventricular failure caused by reduced oxygenation of the lungs, mediated via the mechanism of pulmonary arterial vasoconstriction, causing pulmonary arterial hypertension, increasing right ventricular workload, leading to right ventricular failure. So they're the main two that we see, secondary to LVF and pulmonary heart disease. Now there is a condition called idiopathic pulmonary arterial hypertension, where the pulmonary vessels constrict for no apparent reason and become fibrosed. So that will also cause right ventricular failure. We could mention others. The valve disease is probably fairly obvious, the valve diseases. So if there's disease of the tricuspid valve here, or the pulmonary arterial valve here in pink in this diagram, then clearly that's going to reduce the efficiency of the pumping mechanism of the right ventricle, because a valve is a structure to ensure one-way flow of blood. You can get isolated right ventricular myopathies or infarction, it does happen. And they can be left to right shunts for congenital reasons or as a result of damage to the myocardium. But the other one to consider really is pulmonary embolism. Now, this can cause a more acute presentation. Pulmonary embolism. Now, an embolism is a thrombus which is moving. So what happens here is, the most common scenario is there might be what we call a deep venous thrombosis, a DVT. Deep venous thrombosis. And a thrombus is a blood clot where there shouldn't be one. In this case, in a deep vein, it's a deep venous thrombosis. So a thrombus has occurred in a deep vein, normally in the legs. And on this diagram, where would that be? Well, these are the veins here draining the body. So there would be a blood clot in one of the systemic veins there. Now, if bits break off that blood clot, that would form an embolus or an embolus. An embolus would be one, emboli would be several. So if a bit breaks off a thrombus, that's an embolus. An embolus is a bit that breaks off a clot. And that just floats along in this returning venous blood. And as it goes from the veins in the leg into the vena cava, the vessels are getting bigger, so it has no problem, it just floats along. And there's quite a bit of space in the heart as well, so the embolus will go through into the right side of the heart, through into the right atrium, through into the right ventricle, and then it will go off in the pulmonary artery. Now what happens then depends how big it is. If it's a big one, it can block off the whole pulmonary artery. That will cause pretty well instant death. Or it can branch off, it could block one of the main trunks of the pulmonary artery going to the right or the left lung. But what happens is it goes along in the pulmonary arterial system till it gets to a vessel it can't fit through. As the vessels get smaller as we go towards the pulmonary capillaries, and there it blocks off. It blocks off, and that's a pulmonary embolism. So it starts off in the systemic veins, goes through the right side of the heart, and becomes a pulmonary embolism. And I think you can see that if there's a pulmonary embolism, that's blocking off some of the vasculature. If it's a small one, hopefully it won't cause too much problem, but if it's a big one, it certainly will, because can you see that's occluding the blood through the lungs. So that's going to immediately increase the pressure in the pulmonary artery, increase the pressure in the workload of the right ventricle. But also if it's a big one, it's going to stop the blood going back into the left side of the heart. So there's not going to be the blood to enter the systemic circulation. And remember, of course, the first two arteries to leave the aorta are the right and left coronary arteries. So these patients can develop myocardial ischemic chest pain quite quickly if it's a big one. So pulmonary embolism can be an acute cause of right heart failure as well. But more commonly, perhaps, we see this as a result of chronic obstructive pulmonary disease. In my practice, that's the most common way I see it anyway. A feature of chronic lung disease. This cor pulmonale, this pulmonary heart disease, where the lung disease leads to the heart disease.